I'm Dr. Mangesh. I'm a consultant urologist at Asian Institute of Robotic Surgery, and I'm working with two of the eminent senior uro-oncosurgeons, Dr. Jagdish Kulkarni and Dr. V. Srinivas. I thank Dr. Mahendra Bhandari sir and the Vattikuti Foundation for giving me an opportunity. It will be a brief presentation about the number of cases and the spectrum of cases we have done so far. As everybody knows, the advantages are minimal invasive and accuracy, precision, and three-dimensional vision. So far, the program was started in August 2011. We have successfully completed 190 surgeries. In fact, it is 191 surgeries, out of which robotic radical prostatectomies are 155. The mainly the work at our place is limited to urology and urogynecology because it is not a multi-speciality institute and the work done by the institute is a cardiac work. So far we have done 155 robotic radical prostatectomies. Initially the program was mentored by surgeons coming from US, Dr. Mani Menon sir, Dr. Akshay Bhandari, Dr. Sanjeev Kaul. For first 30 cases, the surgeons used to come and mentor us. Later we took over. Initially the cases took long time, maybe 6 hours, 7 hours with significant bleeding. But later as the time progressed, now the average time has come to 110 minutes for a prostatectomy with a blood loss of around 50 to 100 ml. We have done radical nephrectomies. The number is 15. Though the number is increasing, in last 1 year we have done 10 cases. The good thing is radical nephrectomy definitely, robotic had an advantage which I personally felt. We have removed a tumor of 12 by 8 by 10 centimeter with the whole specimen measuring 29 centimeter in length and 15 centimeter in width. So the patient went home on third day without any problems and they are doing well. We have done 4 radical cystectomies. All 4 had ileal conduit and intracorporeal conduits. 4 partial nephrectomies. 1 bladder diverticulectomy with ureteric reimplantation was done. Robotic hysterectomies and myomectomies, the number is less, but definitely the gynecologists are trying to increase the number. There is one ENT surgeon who has come up with a training in Italy. Dr. Vikas Agrawal, he is doing robotic tongue-based excision for sleep apnea, and the results are really impressive. Most of the patients were screened for comorbidities. During the surgery, Trendelenburg position was given with Allen stirrups. Anastomosis was done with V-lock suture. This V-lock has definitely improved the timing. Out of 155 cases, the average age was 64, PSA was 12. The stage range from T1A to T3C. Though the cases are a little bit locally advanced, but initially to promote the program and to get the hand of the instrument, we did a little bit locally advanced cases also. The average blood loss has come down to 160 ml. The complication I'll just quickly enumerate. The bleeding more than 600 ml was seen in 10 cases out of 155. We found a very unique complication, osteitis pubis. Initially, like our instruments used to hit the pubic bones, and because of the inflammation and continuous injuries to the bone, we found that 3 of our patients had significant pain in the pubic region, which on MRI showed the changes of osteomyelitis in the pubic bone. We had 2 anastomotic strictures which required cystoscopy dilatation, and in late persistent complications we found stress urinary incontinence as a significant morbidity, but patients are not very much affected in their life. Postoperatively, the average stay was 3 days with 8 days catheterization. The drop of hemoglobin was 1.3. We had post-TURP robotic assisted radical prostatectomies. The reason for specially mentioning this is these cases had a little bit of inflammation around the prostate, which was The planes, to find out the planes and doing the dissection was a little bit difficult. We had 15 patients out of 155 who had history of TURP. We needed a bladder neck reconstructions in 5 cases because the bladder was opened a little bit proximally. The blood loss, operative time and recovery time are comparatively a little longer as compared to non-TURP robotic. Spectrum of cases in urology, gynecology, ENT and cardiac. We at our place, one ASD closure was done robotically. The patient also did well, and on say 3rd day he was discharged. In general surgeries we have not started so far, but we are looking forward. And definitely robotic has advantages. Only thing is if cost can come down.